Okay, so that's myelopathy. What about radiculopathy? How would someone with a bona fide radiculopathy present to you in interview and in the physical examination? Well, radiculopathy presents itself as a sensory and motor symptoms. It presents with sensory and motor symptoms related to a specific dermatome and myotome, respectively. Sensory symptoms follow the dermatomes, and motor symptoms are found in the myotomes. Remember, dermatomes and myotomes are segmental, related to the segmental levels of the spine. In the cervical spine, we're mostly concerned with the segmental levels of C5 through T1, although that's not all, but that involves and includes the brachial plexus, which is the main concern of the AMA guides. With radiculopathy, the patients will describe a localized region of numbness, of tingling, or other paresthesias. And paresthesia simply means altered sensations, such as tingling, tickling, prickling, pricking, burning, numbness, fire, heat, etc. So they'll describe localized regions of paresthesias in addition to neck, shoulder, and upper extremity pain. They may report improvement in symptoms when raising the affected overhead, which is the so-called abduction relief sign or Bacotti's sign. And we'll talk about Bacotti's sign here as we go. So with radiculopathy, we have sensory and motor symptoms in addition to neck, shoulder, and upper extremity pain. So let me ask you this. In the presence of radiculopathy of the cervical spine, what is the likelihood that the examinee will report neck pain? It's usually pretty high, correct? Radiculopathy in the absence of neck pain is not impossible, but it would be the exception rather than the rule. So in the case of a bona fide radiculopathy, and I want you to think back to some cervical disc patients that you may have had, or radiculopathy patients that you may have had, what is the likelihood that they also have positive physical examination findings for neck pain? Well, it's usually pretty high. So in the absence of neck pain findings, that may raise your suspicion for non-physiologic findings. Okay, so a bona fide radiculopathy should be associated with associated physical exam findings on the neck exam. Okay, now the hallmark physical exam findings and physical exam testing for myelopathy and radiculopathy include objective reflex testing, and I emphasize the word here objective. And I really like reflex testing because reflex testing is one of the very, very, very few truly objective tests that we have. And that's why they're so good, because so much of the QME interview and so much of the QME exam is based upon subjective factors, that it's good to have a completely objective examination procedure upon which we can rely. Now, in radiculopathy, we test for alterations of deep tendon reflexes, the DTRs. In myelopathy, we test for pathologic reflexes, and the pathologic reflexes are not deep tendon reflexes, they're actually superficial or skin reflexes. So for radiculopathy, we test for the deep tendon reflexes. In myelopathy, we test for pathologic reflexes. So let's review here some of the concepts that you'll remember back from your chiropractic school or medical school or osteopathic school training about reflexes. Okay, according to Stedman's Medical Dictionary, a reflex is an involuntary and nearly instantaneous movement in response to a stimulus. And I like reflexes for that reason, because they're involuntary and they're nearly instantaneous. So they bypass the examinee's subjectivity, and they bypass the examinee's conscious control. Now, I have heard cases where there are some yogis and other gurus that can exercise conscious control over otherwise autonomic functions such as heart rate and respiratory rate and gastric motility and all these other things. However, I've never yet heard or read of a case where an examinee can consciously control a reflex, because a reflex is involuntary. So I love reflex testing for that reason. It's really one of the very few, if not the only, truly objective examination maneuver that we have. Now, with regards to the deep tendon reflexes, we'll go over first the deep tendon reflexes first, and then we'll go over the pathologic reflexes associated with myelopathy second. But with regards to the deep tendon reflexes, there's 6 components of a deep tendon reflex arc. And let's review each of these one by one so that you refresh your memory about what it actually is that we're doing when we take out our reflex hammer and we tap around on the bicep tendon and the patellar tendon and the Achilles tendon. What is it that we're actually doing? And the reason I want to reinforce what it is that we're actually doing is because I want to reinforce to you what it means to actually have normal reflexes and what it means when we have normal, brisk reflexes. Remember, the reflex is a truly objective test. So a normal reflex tells us something. Okay? So the first component of a deep tendon reflex is, number 1, the stimulus. The stimulus. Now, when we're talking about deep tendon reflexes, the stimulus is a rapid stretch of a tendon and or muscle. The stimulus is a rapid stretch of a tendon and or muscle. And we apply that stimulus with our reflex hammer. That's what the reflex hammer does. It applies a rapid stretch to a muscle or a tendon. Okay, the second component of the deep tendon reflex is the receptor. The receptor. You have to have a specialized receptor in the muscle or tendon to be able to sense or detect the stimulus. And when we're talking about deep tendon reflexes, the receptor that we're talking about is the muscle spindle located within the intrafusal fibers of the muscle belly of the muscle that we're testing. And we'll go over which specific muscles we are testing here in just a minute. Now, these muscle spindles are specialized receptors. And if you remember back to Neurophysiology 100, you remember the structure of the standard neuron. Had a cell body, had an axon, had dendrites coming all off the cell body, and at the end of the axon are dendrites, little receptors that pick up stimuli in the periphery and bring those impulses, conduct impulses towards the neuron cell body. Well, these muscle spindles, you can think of them as specialized dendrites. Now, as we go on and we discuss these specialized receptors, we'll find that these are not actually dendrites. We don't call them dendrites. We call them peripheral processes. But you can think of them as a specialized receptor ending that are located, in this case, in the belly of the muscle that we're testing. Okay, and we call these special receptors muscle spindles. Okay, the third component of the reflex arc is a sensory nerve or a sensory neuron. Now, it's the sensory neuron, it's the job of the sensory neuron to conduct impulses up this specialized dendritic ending that we call a muscle spindle. It conducts these impulses up this peripheral process up to the nerve cell body. Okay? And where are the nerve cell bodies of these neurons located? Well, these nerve cell bodies are located in the dorsal root ganglion, immediately adjacent to the spinal cord. And once this impulse travels up the peripheral process and reaches the nerve cell body in the dorsal root ganglion, the impulse then travels from the nerve cell body through its central process and or axon, which ends in the spinal cord in the dorsal horn of the spinal cord. Now, interestingly, the dorsal horn of the spinal cord is somatotopically arranged. Somatotopically arranged such that somatic, skeletal, structural impulses arrive at the most proximal part of the dorsal horn of the spinal cord, whereas visceral information gets projected more centrally in the dorsal horn of the spinal cord. The fourth component of the reflex arc is then therefore the spinal cord, where these central processes or axons terminate. And once in the spinal cord, these central processes or axons make a synapse, make a junction, make a connection then with the fifth component of the reflex arc, which is the motor nerve and or neuron. Now, it's the job of the motor neuron to carry the impulse back to the effector. And in the case of deep tendon reflexes, we say that the effector is a muscle. Now, with other reflexes, we could have other effectors, such as glands, in the case of glandular reflexes, or we could have smooth muscle in the case of intestinal reflexes. But here we're talking about skeletal structures, so in this case our effector is a skeletal muscle, such as the bicep muscle, the tricep muscle, etc. So it's the motor neuron that carries the impulse back to the muscle, and once at the muscle, the motor neuron makes a synapse, or a junction, or a connection at the muscle, and we call this synapse, we call this the neuromuscular junction. Here at the neuromuscular junction, the motor neuron releases chemicals. In this case, it's called acetylcholine, is released from the neuromuscular junction, and it's the neurotransmitter that then acts on the effector. Now, in this case, finally, the sixth component of the reflex arc is the effector, which we said is a skeletal muscle which carries out the response. Okay, so we started with a stimulus, we end with a response, and in the case of the upper extremities, we're talking about a muscle contraction response of the biceps muscle, of the brachioradialis muscle, and or the triceps muscle, depending upon which reflex it is or which nerve root we're actually testing. So for those of you that have the PowerPoint presentation, here's a diagram that shows the patellar reflex in action. Now with the cervical spine, we're not talking about the patellar reflex, we're talking about more like the biceps or the tricep reflex, but the same concept. And this diagram shows the six components of the reflex arc. First is the stimulus, which is the reflex hammer, coming down and imparting a rapid stretch onto the patellar or quadriceps tendon. The rapid stretch of the patellar or quadriceps tendon creates an impulse to be picked up or sensed by the stretch receptor, the specialized receptor located deep within the muscle belly here of the quadricep muscle. That impulse then travels up the sensory neuron and then into the spinal cord, where it makes a synapse in the spinal cord. The synapse is at the spinal cord, with the motor neuron that then carries the response back to the effector, which here is the quadriceps muscle. So we start with a stimulus and we end with a response, and the response is a quick contraction or a quick jump of the quadriceps muscle. So for those of you that don't have the handout materials, or don't have the PowerPoint presentation, I want you to pull out your handout materials and look closely at this diagram. For those of you that are looking at the PowerPoint presentation, I want you to look closely at this diagram. This diagram tells us what it means to have a normal reflex, or it tells us what it means when we have a normal reflex, or it tells us what structures are properly functioning in the presence of a normal brisk reflex. And I'll give you a way to report your findings. In the case of normal brisk reflexes, I'll give you a way to report your findings in your QME exam that conveys to the reader what it means to have normal reflexes. Because many times when you'll read doctors' reports, they'll simply report their findings on reflex testing by stating that reflexes were normal. Well, for a layperson reading these reports in a cubicle in a tall office building with 100 charts on their countertop, they don't know what it means to have normal reflexes. So I'll give you a way to report your findings that conveys to the reader of your report what it actually means to have normal brisk reflexes. Now, according to the AMA guides, reflexes may be either normal, increased, reduced, or absent. Now, in the case of radiculopathy, we're going to find that reflexes may be reduced. They won't be increased, they will be reduced. However, on the other hand, with myelopathy, the reflexes will be increased. So when you report your findings on reflexes, you're going to use a grading system grading from 0 to 4. A grading of 0 is the grade for absent reflexes. We call that areflexia. Now, you could have areflexia in the case of radiculopathy. In fact, the AMA guys themselves state that an absent reflex due to radiculopathy rarely returns. Now, a grade 1 reflex is described as hyporeflexia. This could also be a finding of radiculopathy. However, how can you tell if a diminished hyporeflexic reflex is due to radiculopathy versus it could be just normal for this examinee? How could you tell? Well, the hallmark test is to test bilaterally. It could be that sluggish or diminished reflexes for this examinee could be normal. What we're looking for is marked asymmetry in comparing one side to the other. Okay, if one side is normal and the other side is sluggish or diminished, that could be suggestive of radiculopathy on that side. Reflex grading between grade number 2 and grade number 3 are considered to be normal and or average. Gradings of 3+ to grade 4 are indicative of hyperreflexia. Again, a grading of 3+ could be normal for your examinee. The way to determine that would be to test bilaterally. And reflexes of 4, certainly hyperreflexive, hyperactive reflexes, perhaps even leading to clonus, would be suggestive of myelopathy. Now, in the cervical spine, we typically test 3 reflexes. We test the C5 reflex, which is mediated at the biceps muscle. We test the C6 reflex, which is mediated at the brachioradialis muscle. We test the C7 reflex, which is mediated at the triceps muscle. And with regards to the C5 reflex, those C5 nerve fibers travel in the musculocutaneous peripheral nerve. With regards to the C6 reflex, those fibers travel in the peripheral radial nerve. With regards to the C7 reflex at the triceps, those C7 fibers also travel in the radial nerve. So I mentioned that here just to let you know that those reflexes can be involved also in injury to the peripheral nerves. It's not simply injury to the cervical spine nerve roots due to radiculopathy that could cause alterations in those reflexes. Also, injuries to the peripheral nerves could result in changes of the reflexes. However, let's think about this. In the case of injury to the musculocutaneous nerve, would you expect to find increased versus decreased reflexes of the bicep muscle? Well, we would expect those reflexes to be decreased. The only time we're going to see increases in reflexes is in the case of cortical spinal tract involvement involved with cervical myelopathy. So let's consider that we've done our reflex testing and we tested the biceps muscle of our examinee bilaterally, and we concluded that the reflexes graded at 2, meaning we felt that those reflexes were normal. What does that actually indicate? What structures have to be working properly in order for your examinee to have brisk and active biceps reflexes? Now, in formulating your answer to this question, you can disregard all of the history, all of the symptoms, all of the present complaints, all of the responses on the activities of daily living assessment, and simply rely on the objective finding of normal reflexes. What do you conclude what structures do you conclude are functioning properly in the presence of normal biceps reflexes? Well, it indicates that the musculocutaneous nerve is functioning normally because the C5 fibers in both directions, sensory and motor, are traveling in the musculocutaneous nerve. And the musculocutaneous nerve, you remember, arises from the lateral cord of the brachial plexus. And the lateral cord is formed by the anterior divisions from the upper and middle trunks of the brachial plexus, which is C5, C6, and C7. So right there, you know that a lot of structures are functioning properly. It also indicates that the left and right biceps muscle spindles, the specialized receptors, the stretch receptors, are functioning properly. It lets you know that the left and right C5 sensory nerve root function is normal. It tells you that the left and right C5 sensory nerve root function is normal. It tells you that the left and right musculocutaneous nerve sensory function is normal. And remember, that's C5, C6, and C7.